Good morning, everyone. I'm going to draw attention to the people in the room here at UBC Okanagan, and I do want to welcome everyone who's joined us online as well. My name is Joan Batorf. I'm a professor here in the School of Nursing and director of the Institute for Healthy Living and Chronic Disease Prevention here at the University of British Columbia's Okanagan campus. So I want to begin by acknowledging that the land on which we gather is the traditional territory of the Sikh Okanagan Nation and their people. And it's really a beautiful day here today, and so we're even more appreciative to be on this particular land. We've got some, for those of you online, the sun is shining, the snow is melting, and I hope it's the same where you are. Today we're delighted to co-host this seminar with the chronic disease, it's actually a chronic disease prevention seminar co-hosted with the Southern Medical Program, Chronic Disease Prevention Program, and the Institute for Healthy Living and Chronic Disease Prevention, and Interior Health and Interior Savings. The last two partners are partners that are joining us in launching for the 6th year in a row, Embrace Aging, which is a month-long series of events to celebrate and raise awareness about positive aging. And we hope some of you have had a chance to attend some of the other events we've had this month. We still have a few more coming up, including one this evening, and so we encourage you to come out. Not all of the sessions are offered by webinar, but like this one, there are a few others that are. So I'm going to first remind people who are on webinar that I'd encourage you to keep track of your comments and questions, and you can put them in the chat box to the right of your screen, and Jaquetta will read them out to our speaker, and so that everyone in the room can hear those comments and questions as well. So now I'm going to call on Kathleen Martin McGuinness, who is Director of the Southern Medical Program, Chronic Disease Prevention Program, to introduce our speaker.
So good morning, I'm Dr. Kathleen Martin McGuinness, and I'm the Director of the Chronic Disease Prevention Program in the Southern Medical Program. The Chronic Disease Prevention Program was established in 2017 as the research arm of the Southern Medical Program. We are still a small program, but I'm very pleased today to introduce to you our newest hire, Dr. Brodie Sakakibara. Dr. Sakakibara is truly homegrown. He's born and raised in Vernon, and in fact he began his academic pursuits right here on this campus when this campus was still a college with a diploma in technology. From there he moved on to UBC in Vancouver, where he completed a Bachelor of Science and then a PhD in Occupational Sciences and Rehabilitation Sciences within the Department of Occupational Science and Occupational Therapy. From then he went on as a Michael Smith Scholar, as a postdoctoral fellow, working at both UBC and Simon Fraser University, and we were very fortunate to recruit him out of his postdoctoral fellowship last year as the newest assistant professor in the Chronic Disease Prevention Program, and he is also currently a Michael Smith Foundation Health Research Scholar. So without further ado, I welcome and introduce to you Dr. Brodie Sakakibara.
Good morning, everyone. Before I begin, thanks, Kathleen, I'd like to thank Dr. Batorf and Dr. Kathleen Martin McGuinness for this opportunity to come and present to you on some of my work. I'd also like to thank all of you in attendance here in person, as well as everyone joining by webinar. So thank you for joining me in my discussion on some of the research that I've done in the past, focusing on what's called the stroke coach, which we really feel is a new approach for secondary prevention after stroke. And I'm going to talk quite a bit about secondary prevention because it's an emerging issue, an area of importance in stroke recovery. This is an overview of my talk today, so I'm going to provide a little bit of rationale about why we developed the stroke coach program. I'll talk about the stroke coach program in detail, and because this is a research project, I'm going to talk about some of the methods that we use to evaluate this program, as well as some preliminary observations and results that I can share with you, and then one quick slide on the significance of the program to wrap it up. So just to start off with some epidemiology and some facts and figures about stroke worldwide. It's estimated by the World Health Organization that 15 million strokes occur each year. Of these 15 million, 5 million people pass away from the acute stroke event. 5 million people go on to continue independent living and resume life as normal. But 5 million people have a permanent disability in terms of physical, functional, and even cognitive impairment that they live with on a daily basis. In Canada, it's estimated that there are 40 to 50,000 strokes occur each year, and that there are more than 400,000 people in Canada living with the effects of stroke. Now, due to population aging, as well as increasing numbers of people with health conditions such as obesity and diabetes, which contribute to having a stroke, as well as a survival rate of 83% after acute stroke events, the number of individuals who will be living with the effects of stroke is expected to increase to more than 720,000 people by 2038. So over the next 20 years, the number of stroke survivors in Canada is almost expected to double. And this increasing number of people who are going to be living with the effects of stroke is concerning for several reasons. One of the concerns that we have as academics is that secondary events after stroke are actually quite common in people who are returning to community living. Research shows that 49% of people who have had a stroke that go back to independent community living are readmitted to the hospital for some reason within the first year after having their stroke. People who have had a stroke are susceptible to comorbid conditions or having multiple chronic diseases. 94% of people who have had a stroke also have another chronic condition such as diabetes or heart disease. If this form of multimorbidity with stroke, heart disease, and diabetes is called cardiometabolic multimorbidity, and this specific form of multimorbidity has been shown to be associated with higher rates of premature death. And so this is an area that we want to reduce, is the area of comorbidity after having stroke. Perhaps what's most striking after having your initial stroke event is the rate of secondary strokes. Within 1 year after having a stroke, it's shown that 16% of people will go on to have another stroke, and 33% of people who have had a stroke will have another stroke within 5 years of the initial event. In fact, in the United States, of the 700,000 strokes that occur each year, 25% of those strokes are secondary events. And this has both social and economic implications, because recurrent events or secondary strokes are associated with higher levels of disability, increased mortality, and increased systemic costs. And so secondary prevention efforts are increasing in importance. And this is probably especially true for secondary prevention efforts within the first year of having a stroke, because as I show here, it's within the first year that we see the highest incidence of secondary events. So when we talk about secondary prevention, we have to develop an understanding of what some of the things are that lead to having a stroke, and these are called stroke risk factors. In a large interstroke study of 6,000 individuals from 22 countries around the world, they identified these 10 risk factors, or things that contribute to having a stroke, to account for 90% of the risk of stroke. So if you take a look at these risk factors, and if you were to sort of categorize them into a couple of different categories based on their similarities, how would you categorize these risk factors? So we have hypertension, high blood pressure, poor diet, physical activity, smoking, alcohol consumption, diabetes, high apolipoprotein, which is cholesterol, body composition. If you were to split these up into a couple of different categories, how would you categorize them?
I would say something you do something about.
Yeah.
Something you stop.
As a result, absolutely. And you have that, absolutely. Any other thoughts? Check out.
Well, could you just repeat that? So our guests could hear you.
So the gentleman in the audience identified that some of these risk factors are things that we can actually control and manage versus other things that we just have, for example, health conditions such as diabetes. And that's absolutely correct. And where he's going is that if you take a look at these risk factors, you can actually categorize them into, I guess you could say, lifestyle behavioral risk factors versus more health condition or physiological factors that might contribute to having a stroke. If we put this another way, this is sort of a causal continuum of stroke and many other chronic diseases. And so what's interesting is that the lifestyle behavioral risk factors can also influence those health conditions or those physiological risk factors, which are the direct influencers of stroke prevention and stroke. And so if you really want to get at the root of the cause of stroke, then it's really about lifestyle modification, modifying our physical activity, diet, nutrition, stop smoking, drink alcohol in moderation, and manage your stress a little bit better. Now, despite knowledge of the high likelihood of secondary events and recurrent stroke, and knowledge that many of these stroke risk factors can be reduced or eliminated through healthier lifestyles, many individuals who have had a stroke still have lifestyle behaviors and health conditions that could be better managed, as I identify here. 62% of people who have had a stroke continue to have high blood pressure. 79% are overweight. 18% continue to smoke. And the vast majority of people who've had a stroke are not active. They report non-adherence to medication regimes and have unhealthy dietary patterns. Now, although it might be expected that people who have had a stroke would really want to reduce the risk of having another event, another stroke, it seems easier said than done, because many individuals who have a stroke have lifestyle behaviors and health conditions that likely they were living with before that contributed to the stroke in the first place, which really increases their risk of having a secondary event. How can we let this happen as health professionals? I'm sure there's many reasons. One reason, or I think a key reason that we've come up with, has to do with this statement. There are alarming levels of neglect in terms of chronic disease management after having a stroke. Now, although this statement was made in 2008, it's still very true today. So what happens is we keep people alive after their acute stroke event. They go to rehabilitation and they regain their independence. After they regain independence, they're discharged back to their homes and for community living. And so they're going from one environment to another, one environment in the health system where they have complete support from health professionals managing their health and well-being, to another environment back out in the community where they have very few supports. And the speculation is, as a result of this transition, going into the community where there's very few supports, that's part of the reason why we're seeing such a high incidence or high numbers of secondary events after acute stroke events. And so what this suggests is that there's a need for secondary prevention programs. But when we're developing health programs, we also have to ensure that these new health programs also adhere to indicators of what's called healthcare quality. So yes, we need secondary prevention programs after people have discharged from hospital rehabilitation, but we also have to make sure that these new health programs are accessible and they're cost effective. So there's a need for easily accessible, cost-effective programs for secondary prevention after stroke. But more specifically, there's a need for these type of programs that really facilitate lifestyle modification, really to improve the long-term health of stroke survivors and ultimately to reduce the risk of secondary complications and recurrent stroke. And I think the key terms here are long-term health and lifestyle modification. Lifestyle modification meaning we need to change lifestyle behavior, so physical activity, diet, nutrition, stress management. And so the question is, how do we do this? How can we change behavior and make sure that people choose the right path rather than reverting back to lifestyles that contributed to their event in the first place. One area that's emerging in the stroke literature and stroke recovery literature has to do with what's called self-management. So evidence shows that sustained changes to behaviors require self-management processes and skills. Self-management is really about taking control and being in the driver's seat. Self-management is about being a partner in your own healthcare, a partner that's proactive in managing health to minimize downstream health complications, rather than being simply a passive recipient of healthcare. So we have to be really proactive and manage our health for long-term health benefits. In this review of 122 papers examining behavior change interventions to improve physical activity and healthy eating, these authors identified 26 different techniques to change behavior. Well, first they found that behavior change interventions actually do work, and in those behavior change interventions they looked at 26 different sort of techniques that led to the behavior change. And what they found was that self-monitoring of behavior was the single most important behavior change technique to change behavior. So self-monitoring in terms of keeping track of the number of steps that we take each day, keeping track of our activity levels and what we're eating through physical activity and diet diaries. But what's interesting is that the authors identified that self-monitoring in combination with other self-management skills and processes led to significantly improved changes than unilateral approaches. So self-management processes such as goal setting, action planning, and obtaining feedback on what we're doing from other individuals that we respect. And so self-monitoring in combination with goal setting, action planning, and feedback led to better improvements than self-monitoring alone. What's interesting in this paper as well is that each of the interventions, or the average number of behavior change techniques that were observed in each of the interventions was 6. So each intervention used 6 different techniques to change behavior. And so what this suggests is that multimodal programs, or programs that use several behavior change techniques to develop self-management skills such as self-monitoring, goal setting, action planning, are successful at changing behavior and hopefully sustaining those behavior changes over time. And this takes me to the Stroke Coach program. The Stroke Coach is a telehealth intervention. Telehealth meaning that the program is delivered entirely over the telephone. This program is to promote healthy lifestyle behaviors after stroke. It's a 6-month program that really works to develop self-management skills and emphasize the use of those self-management skills over time to experience long-term health benefits. The Stroke Coach is comprised of 3 key areas. So the first is a self-monitoring kit. We provide individuals with various things, and I'll talk about these things later to help self-monitor their behaviors. We provide individuals with education and information through a self-management manual, and we also provide individuals with lifestyle coaching. And I'm going to go through each of these components right now. So in the self-monitoring kit, we provide individuals, and they get to keep this kit. We provide them with an activity monitor to keep track of their daily walking physical activity, the Fitbit. We also provide individuals with a blood pressure monitor or blood pressure cuff. Hypertension is the #1 risk factor for stroke, and so we provide them with a blood cuff to a blood pressure monitor to keep track of their blood pressure. What's interesting about blood pressure is that it can be reduced or better managed through physical activity and diet nutrition. We also provide individuals with physical activity and food diaries for them to keep track of their activity and what they're eating. The fourth component in the self-monitoring kit, we provide individuals with what's called a health report card. And so when individuals are enrolled into the Stroke Coach, we do an assessment of their various lifestyle behaviors, and we provide them with a grade depending on the response their grade ranges from A to F. Everyone knows what a report card is and a grade. And so we assign for each of these lifestyle behaviors that you can see in the left-hand column, we provide them with a grade. So for example, this person here for physical activity frequency has a grade of C. So there's a little bit room for improvement. These grades are derived from Canadian professional guidelines. So physical activity guidelines as well as the food and diet, Canada's food and diet guidelines. Individuals are also provided with a sheet explaining what each grade means and what needs to happen for them to transition from a grade of a C to a D to an A. The second component, the self-management manual, is a large document that we developed that provides information about stroke, why the person might have had a stroke, the risk factors for stroke. We also provide information about self-management. So what self-management is, what are the key self-management skills and how to develop those skills. And we also provide information about self-management for secondary prevention. And so we identify things that individuals can do for themselves to better manage their health and well-being for long-term health benefits. Particularly, we identify things that people can do themselves to increase physical activity, eat healthier, and better manage their stress. And the third component that really brings everything together is lifestyle coaching. And as I mentioned, this lifestyle coaching is delivered entirely over the telephone. And so we can have coaches in, say, Kelowna here, but we could deliver this service to people in Revelstoke or Vernon or Golden. The stroke coach is 6 months in duration, and in the 6 months, participants receive 7 telephone sessions on a one-to-one basis with one of our trained lifestyle coaches. And the role of the coach is really to collaboratively work with each of our participants to improve their lifestyle behaviors. The coaches refer to the health report card. They identify areas that could be improved and that they could work on for the duration of the 6-month program. Those would be considered long-term health report card goals. And then they work with participants to develop short-term action plans that the participants could actually achieve within or between each of the coaching sessions. We put our lifestyle coaches through a brief training workshop. We have participants attend what's called a motivational interviewing workshop. And we also train our coaches to administer what's called the 5A clinical counseling model to help individuals or to work collaboratively with the participants to set goals and develop action plans that they can work on. I'm going to go through each of these really quickly here. So motivational interviewing is a person-centered form of guidance to really elicit and strengthen motivation for change. I wouldn't consider that this stroke coach intervention as a true motivational interviewing program, but rather we use motivational interviewing techniques to overcome ambivalence to change and strengthen motivation to change. Techniques that we use are open-ended questions, reflective listening, and summary statements. We also train our coaches to administer this 5A counseling methodology. And so in each of the telephone sessions, the coaches will assess the participant's knowledge about stroke and stroke risk factors, lifestyle behaviors. They will advise the participant on the benefits of change and the risks of not changing. They'll agree, they'll work with participants and look at the health report card. They'll identify areas that could be improved, and they'll work with the participants and agree on longer-term behavior change goals. And then they'll assist the participant to develop short-term action plans, and then they'll work to arrange a day and time for a subsequent follow-up phone call to administer the subsequent coaching session and to really ask about, to kind of hold the participant accountable for doing the things that he or she said that they were going to do in the previous phone call. So in sessions 1 to 6, as I mentioned, this is a 6-month program, but in those sessions, or in the program, participants receive 7 telephone sessions. In sessions 1 to 6, the goal really is to collaborate with the participants, develop personalized and specific plans for the person to work on in the 6-month program, to really help them realize their long-term health report card goals. So just as an example here, suppose a coach and a participant identified a goal to increase the frequency of physical activity in the 6-month program. The coach and the participant, they would brainstorm what the participant can do in various situations. The coach would refer to the self-management manual for ideas. They'll identify and discuss barriers to increasing the frequency of physical activity. And they'll brainstorm potential solutions, and the coach will also offer potential solutions. They'll agree on an option to try out, then they'll develop an action plan, identifying the frequency of physical activity, how long, when, and duration. What's also important when we're talking about stroke recovery is also the involvement of caregivers. And so the coach will try to engage the participant to think about ways that the caregiver can help with the action plan. And because this is a physical activity goal, the coach will also encourage the use of the pedometer to facilitate self-monitoring of walking physical activity. Now, through the use of the 5A model and motivational interviewing, the coaches will elicit solutions. They'll elicit solutions from the participants, and this is a key point. This is a very client-centered approach, and so we want the participants to develop solutions for themselves rather than providing solutions for them. And the coaches will help set goals with the individual, develop action plans. They'll review the goals and action plans in follow-up phone calls, and they'll provide feedback to the individual about their performance. And that's the stroke coach. And as I mentioned, it's currently being evaluated right now in a research study. And right now what I'm going to do is talk about the methods that we use to evaluate the efficacy or the effectiveness of the stroke coach and some preliminary observations and results. And so our hypothesis was that the stroke coach is going to improve a global measure of lifestyle behavior in community living individuals with stroke compared to what's called an attention control group. And I'm going to go through this attention control in a second. We use what's called a single-blind, multi-site, randomized controlled trial. Single-blind in the sense that our assessors or people that are collecting the data, they don't know the group allocation, and so they're blinded to whether the person was allocated to the control group or allocated to the stroke coach intervention. We were looking to recruit 126 participants. Now, in order to participate in this study, people had to have a stroke within the past 12 months. They had to have what's called the MRS score between 1 to 4. The MRS is what's called the modified Rankin scale score, and it is an assessment of stroke severity. And so a score of, the total scores range from 0 to 5. A score of 0 means that the person has no symptoms at all and they're continuing with daily life as usual. A score of 5 indicates that the person has severe disability and requires constant care. And so those two extremes were excluded from our study, and people that were included had to have at least some disability or at least some limitations resulting from the stroke, but not completely requiring constant care. Individuals have to be living in the community, so not long-term care, and they also have to have telephone access, and they also have to be at least 50 years of age. I started this project when I was in Vancouver, and so we were recruiting from Vancouver Coastal Health Authority, Vancouver General Hospital, as well as St. Paul's Hospital. We recruited from Surrey Memorial Hospital, and we were fortunate to also develop relations with people in Northern Health Authority, and we were able to recruit people from the University Hospital of Northern BC. And because this program is a telehealth intervention developed to increase the accessibility of this health service, we felt it very important to get people from a more rural location. In terms of the group, how am I doing for time? Good? Yeah. In terms of group allocation, so participants were randomly assigned to one of two groups. Our experimental group, or our intervention group, was a stroke coach program with a lifestyle coach that I just talked about, and participants were had the possibility of also being randomized to an attention control group, which is where we delivered a memory training program with a memory coach. And so people in the attention control group of the memory training program received, it was a 6-month program, and in that session they received 7 telephone sessions from a memory training coach to help improve their memory. What's interesting about this attention control group is, or this project in general, is that regardless of the program that you're allocated to, participants receive some benefit, either in the form of lifestyle modification or memory training. The key component here is that the memory training program, they didn't receive any benefit that would confound our outcome measures. That makes sense. And these are the variables and measures that we use in our evaluation. So participants, we collected data on participants before enrolling in the study, 6 months after, later, or at the end of the stroke coach program, and then we collected data at 12 months, so 6 months after the end of their program. And our primary measure was a global measure of lifestyle behavior. This is a composite measure and included questions on physical activity, diet, nutrition, stress management, health service, navigation, spirituality as well. Our secondary measures there, as you can see, were specific to individual risk factors, looking specifically at activity, diet, stress management, medication adherence, as well as cardiovascular risk factors, such as hypertension, glucose, as well as cholesterol levels. So some of the preliminary observations. This is, the study is still ongoing, and so I can't look at the data, and so I'm just going to offer some of the preliminary observations right now. We have recruited 126 individuals. The age that we're getting individuals at is about 67, 68 years of age. Most of the individuals that we're getting are male. Most people have around 14, 15 years of education, and we're getting people between 7 and 7.5 months after having their stroke. So relatively soon, I would say, after discharge from hospital and rehabilitation, which is really what we wanted to help with that transition from hospital back out into the community. Based on some of the exit interviews that we administered to people in the stroke coach program, 94% agreed that the program helped manage their condition and develop healthier lifestyles. 100% so far agreed that the goals were developed collaboratively and that the coach helped to develop realistic and achievable action plans, which is really important, the achievable action plan bit. And we were happy to see that 100% would recommend the program to others. These are some quotes from some of the participants that have completed the program. The coach helps the participant, to better understand their condition, which is really important. You have to understand your symptoms after having a stroke to better manage your health. Participants felt empowered to do more for themselves. The coach was encouraging and talked in a positive way. Under support there, the participant identifies an outcome of helping to lose weight and become stronger. I like this last quote having to do with education. The participant stated that the program provided her with more information and education than the actual health system did. So as I mentioned, this is an ongoing study. We haven't looked at the quantitative data or done any statistical analysis on the outcome measures or variables that I identified previously. We're done recruitment. Our last participant was recruited in January, but because we follow individuals for a year, we won't have or be able to analyze some of the, do some statistical analysis until 1 year from January, so January 2020. And significance of the stroke coach, well, this just relates back to the rationale. We believe that the program has the potential to improve health behaviors of people after stroke. The data will tell us when we're able to analyze that. And the evidence that we develop, we hope to ensure that it will promote self-management for healthy living through the use of home-based, low-cost technologies, and ensure that self-management is part of the stroke care pathway. And really to extend the stroke care pathway into the community and to make people realize that health does not end after you're discharged from hospital and rehabilitation. Rather, it's an ongoing thing. And sometimes, people, once they have been discharged, they need help managing their health. And we hope the stroke coach could fill that gap. Just acknowledgement to some of the funding organizations that have supported our work. And are there any questions? And thank you. That's all I have to say. I noticed I'm a little bit early.
No, that's all right. Wonderful. Okay, so we do have some time. We do have some time for questions and comments. And I'd encourage those people who are joining us online to type your comments or questions in the chat box, and Jaquetta will read them out. And I'll invite people in the room to also just raise your hand. And if you can speak loudly, or actually we'll repeat the question so that people online can hear it. We have the microphones up here, just so that they can also be included in the conversation today. So, yes, we have one question in the room.
You had the participants evaluate themselves and the effectiveness of the program. Did you also have the coaches assess, in their estimation, the effectiveness of the program for the people?
Yeah, no,
Okay, do you want to repeat
Sure.
the question?
So a question from the audience member was around our evaluation of the stroke coach. So we have quantitative questionnaires that the participants actually complete, and that's going to determine whether the stroke coach actually worked. And the question was if we have something similar to evaluate the perspective of the stroke coaches and get the stroke coaches thought as to whether the program worked for their participants. It's a great question, absolutely, because yes, stroke coaches are an integral part of the program. The short answer is we do not evaluate or obtain the coach's perspective on the success of the intervention. But in our exit interviews, we ask the participants about their experiences with their coach and their satisfaction with their coach. And hopefully that would be some sort of recognition of whether, hopefully that would mirror the coach's perspective as well. If the patient was, or if the participant was satisfied, then hopefully the coach would say something similar.
I have a question here. So, can you help us understand why the majority of the participants in the studies was male, when Heart and Stroke says, recently published in February, women are at a higher risk of reoccurrence than men?
No, it's a great question. And, I don't have an answer for that. But I can rationalize and just say that, this was a voluntary program. We let as many people know about the program as possible, and people self-selected to either participate or not, and it just so happens in our case that more men chose to participate than women.
Can you tell me if the facilitators were male or female, and if you think that might have made a difference, and how you checked on the coaches, in terms of whether they were doing what they should be doing through each of those telephone conversations?
Yeah, absolutely. So we have 3 stroke coaches, 3 trained stroke coaches. 2 of them were female. And 1 was male. One was a physical therapist, 1 had a master's degree in rehabilitation sciences, and 1 was a kinesiologist and had a dietetics background as well. Whether the coaches had an influence or the...
Yeah, I guess I was just wondering about the gender dynamic, if that made any difference.
Sure.
Yeah.
We didn't match. We didn't match really the participants with the coach, Rather, the participants, as they rolled in, we just assigned them to a coach who had capacity to take on additional clients. Based on our exit interviews, really, I would say that it didn't make a difference because all our coaches, this is what, from the exit interviews, were very knowledgeable. The satisfaction was very high, regardless if it was one coach or another. In terms of feasibility, yeah, absolutely. 6-month program, sometimes coaches might wander off and not follow our protocol as anticipated. And so our coaches, they recorded, I had them record at random instances their sessions, and I listened to them on, or a research assistant listened to them. I also sat in on some of the coaching sessions, and I had a checklist to make sure that they were addressing that 5A counseling model. Yeah.
A very quick question. Were any of your stroke coaches stroke survivors?
It's a great question, and the answer is no, but I don't see any reason why not. So down the road, that is a potential area that we could address and expand the stroke coach and test the applicability of having a person who's had a stroke to implement the program. You don't need a health background to be a coach, but rather more so along the lines of understanding what self-management is, the 5A model that I talked about, as well as strengthening and providing encouragement and motivation to the individual. People who have had a stroke, the benefit of that is that they can talk from their experiences to people with a new stroke, and that might be beneficial to those individuals to learn from previous experiences.
Thank you. Were there any people with aphasia involved in research?
So that was actually one of our exclusion criteria because our program was delivered entirely over the telephone. People with severe aphasia were unfortunately excluded for that reason. We did have a couple of people with minor aphasia, but they were able to communicate, and the stroke coaches were able to understand everything that the person was talking about.
So another question. Could you share with us what are the challenges of the stroke coach program?
Some of the challenges, that's a great question. Well, I'll talk about some of the benefits while I think about some of the challenges. The protocol actually that we use is very, very simple to administer. And when I was training the coaches, they were very happy to see that the protocol that we used, following the 5A model, developing goals and developing action plans, it was actually quite simple and developing motivation for the participants to follow. So for that reason, I think part of the reason why I'm sort of hesitating on the challenges is because it was a really simple program for the coaches to deliver. The challenge that we are facing right now is we're nearing the end of the research process, and so we're starting to think about where in the community or in the health system where we can actually implement this program to offer the program to British Columbians. Are we going to implement it in the community, or are we going to work with health professionals? Where are our coaches going to be located? Who is going to provide us with startup funding to actually get this off the ground?
Other questions?
I have a couple coming.
Oh, okay, they're typing. Okay, good. Perhaps just while people are typing, I might ask a question about how did you determine that 6 months would be the ideal time frame to provide coach support?
Yep,
And
good question.
is there any, and I know that this is a problem, is relapse. I mean, we all make health behavior change, and then over time, sometimes we fall off the tracks and go back to those old habits again. So I'm wondering how you came up with a 6-month time frame and how we prepare people to deal with lapses in their behavior change process.
Great questions. And so as prior to actually developing the stroke coach program, we conducted a systematic review of, I guess you call them lifestyle behavior self-management programs for people who have had a stroke. In that review, we just took the mean duration of the program, which was around 6 months, and so that's what we went with. There's no hard or real evidence base for the actual dose of these sort of interventions, but we went with the mean duration based on our systematic review of previous literature. In terms of adherence, that's a great question. So in the stroke coach program in sessions 1 to 6, we really try to develop self-management skills. So make sure that people are self-monitoring their behaviors. They're able to identify goals that they want to work towards, as well as really developing achievable short-term action plans. In the 7th coaching session, the coaches review with the participants their successes and the transitions from lower grades to higher grades. And this is all about developing confidence in the person's ability to actually, make changes on their own. The coaches also emphasize that you are really the one who identified your long-term goals. You're the one who developed these action plans, and now look what you've accomplished in our 6-month time frame. And so it's a combination of developing some of the self-management skills and emphasizing the use of those skills over time. In the last session is really developing or preparing the individual to tackle health behavior change and adherence on their own without the support of the stroke coach.
Great, thank you.
Are you thinking about looking at long-term effects of the stroke coach?
It's a great question. Long-term is very subjective. So our program is 6 months in duration, and in our research study, we follow individuals 6 months after the end of the program. So there is a longer-term follow-up. We haven't thought about following up with individuals any longer than 6 months after the end of the program.
Do you feel the stroke coach model could be used for other health conditions, for example, heart attack?
Absolutely. This is a very applicable process for different chronic diseases. Yes, our stroke coaches were trained to have knowledge about stroke and stroke risk factors. The self-management manual, there's one section in there about stroke and what it is, with a few minor tweaks and modifications to the manual, as well as to the workshop to train the coaches. Yeah, this model or this program is very applicable to other conditions that have similar risk factors, such as heart attack and diabetes, those cardiometabolic conditions.
Mary.
Thanks so much for the nuts and bolts of this week's RCT. I'm curious about recruitment, in terms of how general roles the 126 are to so like was it through healthcare providers, posters at hospitals, how long does it take, and the SDS of
Oh, the social, yeah.
I'm going to repeat the question.
Sure. Sorry?
like, for example, 15 years of education for individuals who are 70 now seems high. And that, and sorry, one more part of the question is, what the differences in UNC demographics?
Right. Right. Yeah, okay, so the question from the audience member here, Dr. Jung, was around recruitment and the generalizability of our research findings. He was asking about how we recruited individuals into the program, and the second part of the question, refresh my memory again, was, socioeconomic status of individuals, again relating to the generalizability of our research findings. And so we recruited individuals, yes, from hospitals, as well as through the community, attending stroke recovery clubs and making presentations to people living in the community. Yes, we put up posters in community centers as well as at hospitals. but our primary method of recruitment was through hospitals and the use of neurologists to talk to participants about the program and recruiting individuals from stroke prevention clinics. We do have representation from Northern Health Authority, so people from more rural regions, as well as from the lower mainland, the larger city centers, as well as a suburban area, Surrey, I guess, which you would consider still pretty urban. In terms of the socioeconomic status, I haven't looked at those details as of yet, so I can't comment on it, but it's a good point and something for us to definitely consider when we're taking a look at the socioeconomic status and their involvement in the study. Was there anything else there?
Maybe is there a plan to look at differences between your
UNB. That's a hard one because even though we were in Northern Health Authority, our recruitment rate wasn't as high as it was elsewhere. And so I think we had, 10 people from Prince George relative to 116 from Vancouver and Surrey. And so it'll be difficult to do any, I guess, statistical analysis, but certainly we will look at some, just compare the means and median to see if there was any sort of, if there's a large difference, yeah, but nothing statistically.
I have a question here. Why was 50 the minimum age for participation? Adults under the age of 50 might struggle even more than survivors who are older due to having younger children and loss of earning potential.
Yeah, and so we wanted to keep our sample as homogeneous as possible. The fact of the matter is still the highest incidence of stroke is among older individuals, really 65 years of age and older, and so we were deviating towards the younger end by going through to 50, but it's, and I appreciate the comment, yes, younger individuals, the rate of stroke in younger individuals is increasing, and yes, the consequences of stroke could be more of an issue for these individuals who are working and who have a family. But for our research purposes, just to keep the sample size or sample as homogeneous as possible, we had to limit it to what we considered an age that people would reflect similarly in some of their outcomes.
Did any of your stroke coaches ever have problems reaching their participants?
Yeah, so sometimes, people scheduling, absolutely. There were instances when coaches arranged a day and time for a phone call, but the participant didn't answer. So our protocol of 6 months was flexible in the sense, we recognize that people go on vacation and coaches have priorities as well, and they go on vacation or people might get sick. And so absolutely, our protocol was somewhat flexible, and at times, coaches did have issues connecting with participants as well. I don't think any participants, I'm certain, there was maybe one participant in the stroke coach program that dropped out due to lack of interest, but for the 63 other individuals, they all are in the program or have completed the program, and they might have had issues being reached by telephone, but it wasn't due to lack of interest.
Do you think you would use this program for general prevention of stroke?
Well, it could definitely be applied to general prevention because from our perspective, the risk factors for secondary prevention and subsequent stroke are basically identical to primary prevention as well. And I guess the population for primary prevention could potentially be all of us. And so the difficulty, I guess, then would be, do we offer it to everyone, or how do we narrow it down to individuals that might be at higher risk for stroke?
So I have a question. So I'm wondering if, based on this study, you'll be able to estimate some sort of cost for implementation based on benefits, like, for example, do we actually see a reduction in those hospitalizations?
Yep.
Because if we wanted Interior Health to implement it, for example, they're going to want to know how much is this going to cost.
Absolutely.
Yeah.
Yeah, so it's a great question. One of our outcomes that we're looking at is actually health resource utilization. And so we ask individuals the frequency of visits to health professionals, the doctors, family doctors, ER visits, allied health visits, and based on BC Medical Services Plan, we're costing out those visits. We also ask individuals about medication use, and we're costing out the medication use as well. And so we will be able to develop, I guess, some indication of
Cost savings.
cost savings based on pre-enrollment into our study versus post-enrollment in our study. In terms of the cost to actually deliver the program, it is a low-cost service delivered using a low-cost technology, the telephone. There will be costs of, training the coaches and the coaches' time to actually deliver the program. We offered our participants the activity monitor and the blood pressure cuff. That was, and they get to keep those over time. But individuals, if this program is implemented in the community or within Interior Health, there's a couple of models there. Individuals might already have their own activity monitor and blood pressure cuff. By no means should that be, they should be excluded for the study if they don't have those technologies. Interior Health or whatever organization that takes this on could deliver or could make activity monitors and blood pressure monitors available to them, whether they give it to them forever or they return it after the end of the 6-month program. That could be a consideration.
So a nice comment. This is a wonderful initiative. Thank you for working so hard to improve the life of stroke survivors. And then, looks like a question. Is RTW status a component that would be evaluated in the duration of the program?
Return to work?
Yeah.
No, that's something that we haven't looked at, actually. I don't think in any of our questionnaires do we ask people their work status or employment status. So no, we're not measuring it. The primary purpose is lifestyle modification, and so that's really the focus of. And just relaying back to a previous comment about our age criteria, and the mean age of the participants is around 66, 67. Most of these individuals would be retired or are retired, actually.
Great. Well, this has been absolutely fabulous, and I'm sure that we could go on talking about stroke prevention for a long time. But our time is up, and I want to have everyone join me in thanking Brodie for this fabulous presentation and this fabulous work, and we look forward to hearing about the results when they're out. So thank you so much. And I want to thank everyone for joining us today. It's been really fabulous having so many people online and also people in the room. I'm so glad you found parking.